Hello, everyone. It's Dr. Sauscha here with Clinical Unfiltered. And so today, give me your hearts, your minds, your teeth. And we are here with Dr. Pauline to get unfiltered about injecting. And so we kind of talked about a little bit about how she started her business and how she began her career in doing injecting in her clinic. Now I want to get into the nitty gritty of actually poking people. And I get this all the time. I've had people who do inject look at, like, when I smile, like, I get a lot of wrinkles around the eye. And I call them my happy scars, and they all want to just, like, start poking me in the face. But, like, what do you do? What, like, you see these little wrinkles on my eye. What would you do about them?
I would only do what you want to do about them, right?
Let's say I did want to fix them. Like, what do you fix? Like, how do you fix them?
So most people, they want to get rid of the lines. And so with that, we have to evaluate things when they're static, when you're not in motion first, right? Are there static lines? If so, that means like this piece of paper has been folded over and over and over. And that static line can't be addressed with just Botox, right? So any kind of neuromodulator would only be treating the muscle. So your orbicularis oculi is the muscle that goes around your eyeball. And that's the muscle that pulls inwards when you're smiling. And that's what's causing those crow's feet that you're seeing. And if you wanted to soften them or get rid of those lines, you would just treat it with that muscle relaxer, and it would then diminish those lines from folding and forming. Now, if you have lines just at rest, so let's say now they're etched in, that's no longer just a muscle problem, right? That's now we need to rebuild that collagen and work on that skin quality. And that's a different treatment. And that's going to be more with like Morpheus, radiofrequency microneedling, and skincare products. That's going to help.
And you have this whole suite. Like, you do it all those different techniques.
Yeah, we have the treatment plans and treatments for all that.
What's the most common injecting, like, problem that you're facing and treating? Like, what's the most common patient, I guess, for these facial aesthetics that you see?
I deal with a lot of lip patients. I think a lot of people who want bigger lips, and I turn down a lot of people because, one, they're probably already overfilled, and then I end up telling them that they need to be dissolved. So they're just trying to find that injector that's just going to inject them. It's not going to be me.
Gotcha. So, you know, it's funny. I'm going to pause and we're going to come back to this. I literally had to listen. I was like, all right, I'm talking to Pauline. I got to, like, learn something about injectors. So I listened to one podcast before this, and that was like they literally talked about that for an hour, about like not treating patients because their lips are so beat up with injections. Like, they've overdone it. And like, they're like, I'm not your person anymore. And that was like the whole, that's it. I'm depleted of my knowledge of injectors.
You laid it all out there.
So, I mean, you brought it up right away. So that must be a common problem that you're trying to manage. So you don't even treat a lot of those cases.
Yeah. So, or it's my own patients that have been with me for years and years. And every single time they're like, can I get more lips? Can I get more lips? And I'm like, I've been telling you no. I will tell you when we can add it back on your treatment plan. But as of now, no, like, you're good.
Okay. Gotcha. So lips are a lot.
Yeah. I've had patients that cheat on me and they'll go somewhere else, and then they'll get overfilled and the filler starts migrating. And then they'll end up back on my schedule. And I know I didn't do those lips because we take photos every single time, right? And then so I go back, because you kind of start gaslighting yourself. We're like, wait, did I do that? Because as dentists, I think we really criticize our work too, right? And I was like, looking back at photos, then I straight up asked them, like, did you go somewhere else and get your lips? And they're like, yeah. And I was like, okay. It makes you feel better. You're like, there's no way I would have done that, right?
So they come in, they've been, let's say they're a new patient, then they're, I guess, sounds like a lot of them for the lips. How does, like, the evaluation process go to the actual, like, treatment? How does that treatment play out?
So the virgin lip patients, I'm evaluating their tissue type, seeing what type of filler I'm going to be able to use. And then I also talk about, like, lifestyle and their habits. If they're straw users, if they're constantly using this muscle around their lips. I'm prefacing a lot of all this as that, like, this area is a very mobile and dynamic area. So you may experience lip migration even if you do everything, but I'm still at least going to tell you what precautions to take to avoid migration in the future, right? So anything in that straw-like movement, you want to prevent from doing. And then I'm looking at symmetry, and then I'm also looking what their goals are. Some people want a 1-to-1 ratio, upper lip and lower lip. Some people want a smaller upper lip compared to their lower lip. I'm also looking at their facial profile. If their lips protrude past their nose and their chin, and by how much, do we need to actually work on their lower face if they have a retreated chin versus actually doing their lips, right? So a lot of people think they are coming in for one thing, but because I'm looking at everything, I'm saying, hey, if I were to choose and I only had one syringe of filler to use, I would probably actually just use it here versus here. And they're open to that.
Are they coming? I mean, I'm assuming they're coming a lot with a photo, probably. They're like, hey, this is my intended lips. Or are they just like, Dr. Pauline, tell me what I should do?
A lot of people want my take on things, but if they are showing me a photo, most of the time it's because they did really good makeup and they did like lip liner and lips. And they're like, I saw this photo of myself and I really want my lips to look like this normally without the makeup. Or they'll use a filter, right? And they're like, I want my face to look like this when I have the filter on. And then I ask them like, what do you like about it? And then I can actually start addressing things and then pulling tools out of my toolbox on what I can use to actually give them that result, right? So we're talking about not just the lip shape and volume, the muscle. So a lot of people have a gummy smile, and that's probably just their chief concern is that like, I'm happy with the size of my lips, but when I smile, it's gummy. So then it comes to a muscle problem. Is your muscle hyperactive and pulling really high up? Is your O oris curling the upper lip under when you're smiling? So it makes your lips look smaller. So these are just muscle treatments with like Botox to relax the muscles, right? And then I'm evaluating their teeth. Do they have small teeth? Do they truly have a gummy smile, even though their muscles are relaxed? Then we can talk about dentistry and how to enhance your smile that way.
Wait, okay. So like what I'm seeing here is like you're seeing like, especially for gummy smile, I feel like someone who isn't a dentist trying to treat a gummy smile won't be thinking about all those other things. What the heck happens to them? You know, like they don't foresee short teeth and they're going to someone else that isn't a dentist. I feel like that would be not a good place for them to get injections for their lip if they're doing it for a gummy smile.
Yeah, we're all a product of our own training, right? So it's like, I think the skilled injectors are going to do their very best with filler and talks as best as they can. But I would hope a skilled injector would be able to refer out, right? And be like, hey, actually, I think this is more a dental issue. And I would have your gums and your teeth evaluated to see if that's the result that you're trying to achieve.
Yeah, I want to, to continue on with the process of kind of evaluating and then going into that treatment process with the lip.
It's usually starts there. And it's like just even this one area. So the face is broken into thirds. There's upper, middle, and lower third. Obviously, we went to school for just this little area right here. And then if you expand out, you can look at the framework of things. And then if you think about the aging process, what happens in that lower third, we start to see more lower teeth than upper teeth as we age as well. Now, what's happening with injectables is they're just filling and thinking this is what's going to make me look more youthful, but that's actually aging them even more, especially in the lip region. They're making this upper lip so full and it's covering more upper teeth. And that's actually aging them because a more youthful smile, you see more upper teeth. That's what looks refreshing, right? And youthful. But people are overfilling the lips. And yes, if you look at the lip at rest, it looks youthful because there's no crepey lines, there's more definition, there's volume, but the patient can't even smile and talk because you covered all their teeth.
So there's like a healthy balance there of like when you're designing that lip design that you're like, okay, we need to bring in the dentition in the frame on top of it. Okay.
Especially from the side profile. A lot of injectors don't understand occlusion and how your teeth come into play. So ideal occlusion, class 1, obviously we're all dentists here, so we know that's going to make a better canvas to work on because you're not having to overcompensate anything. But if injectors aren't evaluating the occlusion from the side profile and they overfill that upper lip, it's going to make that patient look even more ducky. So you can mask things with filler. You can add filler to the chin if they're not willing to go through ortho and actually, address the occlusion issue. Then you can try to bring their chin out and make them look more balanced from the side profile before you even do their lips. And I'm actually very strict on that is that I'm not giving you more lips or I'm not even going to put filler in your natural lips. If you have a retreated chin, it's going to look crazy. You're going to look like Marge Simpson.
So it's Marge look great. I don't know what you're talking about.
No shade to March.
So I got you. So you're bringing out the chin a little bit with a filler material. And again, the pure arrogance. I mean, it sounds like there's a few products that you are using as filler, as Botox. Like, is there multiple filler products, or is there like this is the best filler product? I'm using this. Again, like we don't have any sponsors, so you could say whatever product name you want.
So neuromodulator, that's what's going to relax your muscles. Like earlier, we were talking about your crow's feet, right? So this is what you're going to relax your 11s, like any area that you want to quote unquote freeze the muscle is your neuromodulator. So there's going to be your Botox, your Dysport, your Xeomin, your Jeuveau, and these are all different companies.
Okay, so they're not all Botox.
Mm-mm. So that's just a brand name. So Allergan owns Botox, and Allergan has its own line of filler. Okay. And then Galderma has Dysport and has its own line of filler. And then Revance has Daxxify, which is their equivalent to their Botox, and they have their own filler. So each of these companies have their own neuromodulator, and then they also have their own filler. Now with filler, there's going to be different types of filler in your portfolio. There's going to be different G primes is what we call it, right? So an area where you're going to want to mimic bone or get more protrusion, you're going to want a higher G prime, right? Versus something soft like the lips, you're going to want to use something that's lower G prime because you're not going to want to kiss something that's like hard and stiff.
So G prime equals stiffness. Higher G prime, stiffer. What the hell is G prime? It sounds like a transformer.
It's just like a fancy word for like how stiff and how much protrusion this filler is going to give you.
Okay, gotcha. And it is correlated to the stiffness. And so, okay, gotcha. So on the chin, you said it's interesting. So on the chin, what's your like relative G prime? This chin issue, this class 2 issue that you're trying to bring.
My portfolio, I've played with a lot of different types of filler. And it's kind of like you're an artist, right? So you're going to play with different types of paintbrushes and paint. And so I'm trying to like talk in terms of if you don't know anything about injectables. So within Revance, there's RHA 1, 2, 3, and 4. They made it really easy. The higher the number, the higher the G prime. So anywhere like with your chin, if I want more protrusion, I'm going to use like 3 or 4 versus like the lips, I'm going to use like 1 or 2.
Gotcha. Do you feel like do you find out people misusing it? Like, oh man, you got way too much G prime in your lips.
Yeah, if they're like, oh, I want big volume, voluminous lips, and they're using like this thick filler, that wasn't the way to get there. It's like you want to build over time. You can use softer filler, but you would just do it more often as you're building it versus like dumping concrete all in at one time.
Gotcha. No, I mean, I could see that could be an issue. Like if you probably go too much and distend tissue, that could be tough. That could be tough on the tissue, right? I mean, I'm assuming you've run into complications, and we'll get there in a second, but okay, so then let me ask you, do you have a go-to neuromodulator and a neurotoxin? Do you have a go-to product?
So I do, and it's based off of the patient's history as well and what's lasted for them. I also like review their medical history, and like Xeomin is very pure. So it's all like about the accessory proteins that are in there. And we also don't want to keep using the same one as well because patients can get resistance. So they can actually build up a resistance to this neurotoxin. So it's medication at the end of the day. So
is it possible to get resistant to all of them, or can you keep switching?
If you've been doing it for long enough, not just long enough, but if let's say, so it's like a bell curve. It's a 3-month period. So 1 to 2 weeks is when it starts kicking in. And then a month 1 to 2 is like prime time, right? Right now I'm 1 week post-op. So my muscles are starting to relax right now. And then it'll be completely frozen based off the dosage that I dosed myself. At like 1 month, 2 months is where I really like it. And then it starts wearing off closer to 3 months. What happens with people who get so used to seeing themselves in a certain way, as soon as they see any kind of movement or even a line, they're like, I need more Botox. Okay. And let's say they didn't wait the full 3 months and they're like, I'm just going to go ahead and go and do it. they can build resistance because your body hasn't naturally processed the medication yet. And now you're reintroducing it back there. And now it's all confused because you're like, wait, I have some in here that's not at the 3-month mark yet. And then I have some in here that was just introduced into my body. And then I'm going to start producing antibodies to it. It's like, now I don't even understand what's happening right now.
So there can be a threshold that is less resistant. So you're trying to work the bell curve. Don't overdo the bell curve.
Yeah, so it's dosage. Yeah, so each muscle, based off the strength of the muscle, there's going to be different units that are treatment planned for it. So for instance, your masseters, they're large and in charge, right? A starting dose for masseters can be between 15 to 20 units per side compared to, let's say, crow's feet, right? So someone who has very mild lines around their crow's feet will start at about 6 units. I go upward to 14 units up there, depending on how severe and how strong that muscle is. So it's just based off of the muscle strength. You can actually get overcompensation too if you underdose. So masseters, they're so big, and injectors think that they're helping the patient by saying like, oh, I'm just going to give you a few units to help you out. Now, because this muscle is so strong and you didn't give it the proper dosage of medication that it needs, you only put some of the fibers to sleep. And then the other fibers are like, oh my gosh, where are my friends that usually work with me? I'm actually going to work harder now because my friends aren't around. And when they clench down, it actually pops out like a golf ball.
Okay, so the areas that are unfrozen overcompensate. Oh my God, this units that you're talking about too. So I'm starting to get an idea of like what you got to work with. The units is in reference to like the vial that it comes in, or is that like?
So the vials come in 50 units or 100 units, depending on how you buy them. And then you reconstitute it with bacteriostatic saline. And based off of how you reconstitute it, I do a 1-to-1 ratio. The spread of the neurotoxin is a certain diameter, right? So I do a 1-to-1. So my spread is about a dime size. If you do a 2.5-to-1 ratio, it would spread to like a quarter size, right? So I want more control in my injection site. So I do a 1-to-1. Unless I need a bigger spread, then I would add more bacteriostatic saline to just like that syringe for that specific muscle. So yeah, neurotoxin is based off of units, and then filler is by syringe.
Gotcha. And then like when you're saying dime size, so if you're injecting, your next diameter range of moving your needle to inject is going to be roughly a dime.
Yeah, because it's like surface area spread, right? So the best example is your forehead, your frontalis muscle. That's the only muscle that raises your eyebrows on your face. So many people overdose this area because patients' chief concern is, oh, I want to relax my forehead muscles. So yeah, that's easy to do. You just knock out the muscle. But what else did you end up doing? Especially on patients like me who are hooded, you drop my eyebrow and you made me even more hooded, making me look like I need to go get like an upper bleph now. So with that, you want to dose conservatively to where, yes, you're going to relax the muscle, but you want to keep the eyebrow structure preserved. But you want to spread it enough to where you get enough relaxation across the muscle without getting like that spocked eyebrow. We've all seen that, right? Where after someone gets Botox, like this area on top of their eyebrow was missed. Yeah. So this part of the muscle is still active, but everything else is relaxed. So then the patient ends up looking like this.
So you could make me look like Spock?
I could if I leave that part of your muscle untreated.
I'm gonna kind of dial us back to the lip scenario again, because now I kind of got an understanding of like what you got to work with over there. And I'm gonna actually go down the route of Gummy Smile, because this is gonna resonate with me a lot as I treat a lot of Gummy Smiles, but from a dental standpoint. So they've come in, you've evaluated them for Gummy Smile issue, and I mean, let's pretend they don't have dental needs. Like their size of their teeth are as optimal as they can be. And there's no aesthetic crown lengthening coming into play here. How are you using these? What's your injection technique from that point? And what's the pearls in there? I want to know what's your secret technique, secret sauce?
My secret sauce is just finding out what the actual issue is. So we eliminated that it's any dental issues. So now you want to look at the muscle. So the O-ors is a muscle that goes around your lip in the same manner like how you have one around your eye. It pulls inward, right? So when you smile, so let's say my O-ors is hyperactive. I'm just going to exaggerate this. My upper lip will roll under. So every time I smile, my upper lip rolls under, showing more gum. So all you have to do is relax that muscle and get it to not roll under, right? But there's a sweet spot of how many units you could use. You don't want to just knock that muscle out and the patient is drooling and can't use a straw, can't eat noodles. Each patient tolerates this muscle being treated very differently. Like you could use 2 units, like the minimum on a patient, and they're drooling everywhere. I just wouldn't ever do that again for the patient, you know? It's always a love or hate. I'm like, if you love it, keep doing it. If you hate it, just don't ever do it again. It only lasts 3 months. But some patients, you can do like 8 units and they're like, nothing is even happening, right? So you just have to dose appropriately based off the strength. The next muscle you want to look at is the LLSAN right here. This is the muscle that pulls this upper lip upwards, right?
So that line from like the corner of the lip to the nose, is that kind of
directly downwards? So yeah, so if you have a very gummy smile, this muscle pulls all the way up.
Okay, yeah, so almost like eye teeth to the nose, that region.
Or if you have one hyperactive one, like that's stronger, you can use more units on that side versus this side, and you can create symmetry for the patient in that way. So that will help. And then another thing actually in this region right here, now that we're talking about it, is as we age, our philtrum gets longer, right? And we show less upper teeth. So I actually refer a lot of patients out for a lip lift for a more youthful philtrum.
Not a procedure doing it with that. You're talking about actual surgical procedure, the lip lift. Gotcha. So, it sounds like this problem mostly solved by freezing the muscle, not so much fillers are involved yet? Or is there some scenarios where like, okay, we're going to fill the lip up to block out the excessive gingiva?
I hydrate lips, so you want to be mindful of the vermilion border and also the wet dry line, right? Most people have deficiencies along that wet dry line. Like some people have an M-shaped lip right in here, and you can fill in this area strategically, but you want to be really mindful because what I see a lot of is people think where they're placing filler is where it's going to stay, and it's not. And it migrates along that wet dry line. So that's where you start getting those lumps and the bumps when they smile and you see it. So you just have to really strategically place it and build over time. There's different planes, different techniques that you have to use to make sure that you are placing the filler where you want it and it's going to stay where you want it.
Gotcha. So there can be a combination on the gummy smile issue where you're doing filler and freezing to help eliminate the problem or reduce the problem, I guess.
Yeah, that's a pretty common treatment plan. It's going to be relaxing the muscle and giving it volume.
Filler or injecting technique. Like, what's your favorite patient that walks in and you're like, oh, I love this kind of case? Or, like, I feel like some people, it's either they love doing it because it's fun from a technique standpoint, or they love doing it because it's so damn easy. It's, successful. What's your favorite? What's your favorite technique?
I love when patients look refreshed, right? That's all I'm trying to achieve. These are my goals, is just making them look like the best version of themselves at this point in their lives. Like I'm not trying to reverse years. So I love the patients that are open to hearing the overall plan in terms of science and symmetry and where you're losing volume, right? So a lot of loss is happening in the temples right here. We're hollowing out here. And this is an area that gets ignored. And people think they want more lips or they want under eye filler. But it's like the temples, this is your structure that's one holding up your eyebrow. If this starts collapsing, then your eyebrow starts collapsing, right? So if you just maintain this area, it's going to help with a lot of this, right? So start from the upper face down. We're fighting gravity, and people think by filling more down here is the solution, but it's just going to make you look older. So start from the top down. And then the next thing is so many people come in for nasolabial folds. This is their chief concern. I'm getting these smile lines. And a lot of novice injectors will go in and just inject those smile lines. And what ends up happening? They look like apes. We're not meant to be filled here. Like, yeah, you got rid of the lines.
Oh, I know
good.
That look. I know what look you're talking about. I do know that. Yeah. It's funny. You mentioned I have a vivid image of us.
You know who I'm talking about. Like, yeah, you got rid of the lines, but the patient doesn't look refreshed or look any better. So what was the actual issue? It was mid-face volume. We start to lose our fat pads here. So if you actually anchored this and give them contour in their cheeks, their nasolabial folds actually start to disappear, right? So I like to look at the full face versus just little areas. And then the next area I really like to fill is the shadows right in here, because we start to lose bone and collagen right in here. So I like to really balance out these areas. So I like to work on the areas where they're shadowing.
Below the lower lip, like
Yeah.
between, like past the mid. Okay, gotcha. Yeah. I'm trying to paint a picture for all those listening at the gym, and there some people do get videos of this, but not everyone. So like,
Well, you got to go watch the video
right
now.
underneath. Yeah, I know. So right below. I know. I put backlighting. Come on, guys, stop and look at your phone. But so okay, gotcha. I kind of see where that area. Okay.
So that just helps balance out the entire face where they're like, oh my gosh, I didn't even know I need that. Those are the cases that I really love doing, where I put the before and afters, and no one can tell what they got done. You should not be able to point to any of my patients' faces and be like, oh, her lips, or oh, her cheeks. It's like, no, I was able to put a little bit here, a little bit there, just to give you a more refreshed look. So I love working on those patients that just trust me when I say, like, you need mid cheeks, not nasolabial fold filler.
Gotcha. Okay. So I mean, I see what you're saying. So your favorite patients are the ones that they let you control what you're going to do to help kind of improve their look, and almost in a minimalistic way. Like, I see what you're saying. Like, you look at the before and after, and you're like, nothing dramatic happened here. You look refreshed. I get that. Awesome. Yeah, and it probably, honestly, in those scenarios, it's probably lower risk too, a higher reward. You know.
It's pretty risky with filler. So you're thinking of all these arteries that are going through your face, right? So what can happen? Compression, filler can push on the arteries, or it can actually occlude on the arteries. And then oxygen is no longer flowing to the tissues. We just have to know how to manage.
This can go bad. Tell us how this can go bad.
Knowing your anatomy is one thing, but anatomy on each person differs, right? Like, I've worked on cadavers where I'm like, this is definitely where the artery is. And then it's like, oh, it was actually right here. So just knowing what to look for, checking for capillary refill, and then teaching the patient what you're looking for. Because even after they leave, they should know what to look out for, when to reach out to you. So in our system, you can text us photos directly into your chart. So post-op wise, my medical assistant is checking on our patients just to make sure that there is cap refill even after they leave. If there is not cap refill, there is a protocol that you need to know how to handle for your patients, and also guide your patient that this is like important to handle urgently. Right now, there is a time frame in order to make sure that the oxygen goes back into your tissues, or your tissue doesn't die.
What do you like? What's your visual cue on capillary refill? Like,
So cap refill, when you press down, it turns white, and as soon as you release, it fills back up with blood in like within seconds. That's normal cap refill. Now, if there's delayed, or there's pain, or a new pimple that pops up, those could be all signs that there is not oxygen flowing there. And then excessive bruising outside of the areas that you treated, right? Those could all be signs. So definitely coming back in. Compression also can be masked. So you definitely want to just make sure that there is no pain. If you are experiencing an occlusion, you need to make sure that you have Hylenex on deck to make sure that you're reversing and dissolving the filler.
I'm assuming you've been through some complications, whether it's your own or someone else's, correct? I feel like that would be fun to unbox. I feel like we're running out of time here, but like, I almost feel like that's a follow-up episode. Not now, but we'll come back on this. And I want to hear like some of your like botch jobs that you have to fix, or like some complications and how we manage the complications in these kind of scenarios. I think that'd be a fun episode. And again, it sounds like, I feel like I know. Yeah, I always tell people that's like you got to screw up and really know how to handle these kind of cases. Again, it sounds like the best resource to get into. Well, let me ask, because I know you're doing the Lay Academy, but other than that, other resources to get into injectables, like you want to start injecting, where's a good place to start?
Clinically, I would do American Academy of Facial Aesthetics. That's who I took all my courses with, and also who I taught with at one point as well.
Right before we start jumping off today's episode, I have one more question. Have you ever like done or learned about doing injections for papillas?
Yeah, they actually teach that.
No, they do. They teach that.
Yeah, I don't.
Have you ever done it?
No,
have you ever done it?
As a dentist, it goes against my own beliefs.
Okay. More so from like creating a pocket, like recreating a pocket. Is that kind of what you're?
Yeah, it's like aesthetically you're probably like it looks good. Just like filling a nasal labia fold, you got rid of the line, cool. But did you actually address the actual issue, right? So I don't do it, but it's out there and it's taught.
There, like I mean, I obviously treat a lot of periodontal disease, and we'll get, like the problem's resolved, the pocket's gone, but we ended up with a black triangle, and I always thought it would. I mean, like I'm talking like 1-2 millimeters of little puff, where it's at least I know it's normal, like it isn't inflammatory tissue, and it's maintainable at that point. Sometimes in the anterior, not in the posterior. There's no point in doing it in the posterior. Like, what's the issues that happen with it? Like, why can't you do a millimeter? Like, why are you against it? I'm curious.
So I feel like it's okay. In blanket statement, I lean more towards not doing it. But if you are going to do it, I feel like definitely go to a dentist, like you said, like making sure there's no inflammatory tissue, make sure there's actually no periodontal disease. Because I've done it on my friends who's like it's a millimeter, and I know that bone is sound. There's no bone loss. There's so in those terms,
Calculus is gone. Gotcha.
yeah, like
Yeah.
I've done it, but I don't want to put it out there like this is the solution and then people take it and run with it, right? And they're going to injectors who don't understand periodontal disease and bone and the underlying issues. So I don't want them to run with just like that blanket statement.
Fearful of the patient coming in with tons of cavities, just want whitening kind of scenario. I gotcha. Again, thank you, Dr. Pauline Lay. Thank you for getting unfiltered with us today. We appreciate it. Again, her Instagram handle, what was it again? Dr. Pauline Lay. And Lay Dental Spa, if you guys want to get in contact with her. Thank you guys so much for getting unfiltered. We'll see you on the next episode of Clinical Unfiltered.